All right, you guys ready?
Yeah.
Boom. Let's get started. Try your best to pay attention while you suck down some Shan's eggs. All right, so I don't really need to introduce myself. I'm Andrew. I've worked with you guys for 4 years. I can't believe this is the first time I've had the opportunity to teach you. Hopefully many more opportunities in the future. What we're going to talk about today is hypothermia, in particular accidental hypothermia. There are things like therapeutic hypothermia where we actually induce it, but this is the person that you bring in and they're cold and not exactly sure why. I'm going to go through mainly how to diagnose it, how to treat it, your disposition, workup that is warranted in the emergency departments. So warning ahead, I use Celsius in this lecture. I hate Celsius. Actually, I hate Fahrenheit, but I don't know Celsius. It is the international standard. But every guideline you see for hypothermia goes by Celsius. So a nice trick I've always memorized, and the ED, if I need to convert the two, is your Celsius 9/5 plus 32. So I always take the Celsius, I multiply by 9, divide by 5, add 32, and you can do that quickly on your phone because I can never do the conversion really well in my head. But yeah, that's it. All right, so hyper and hypothermia. The body has this beautiful machine where we work very well in a nice range of temperatures. Once we start getting out of those temperatures, things get wacky. Obviously, we get too hot, bad things happen. We get too cold, bad things happen. So today, this is the spectrum we're going to talk about. This is kind of your typical hypothermic patient. This is your classic patient where they're walking down, it's Christmas, they're missing their family, they start getting chest pains, they go down the ground. Someone walks by, luckily Walter Matthau walks by, finds them down, brings them to the ED and they're cold. So this is kind of your typical classic patient, and this is what we call primary hypothermia. So for whatever reason, the patient's out in the cold, and their basilar heat production cannot overcome the stress of the excessive cold environment that they're in. Again, that's primary hypothermia. That's what we think about a lot. Almost the more important kind that can get overlooked and we can kind of miss and misdiagnose is your secondary hypothermia. So this can be from a couple of reasons. First off, impaired thermoregulation. So endocrine, weird endocrine disorders, especially like thyroid, neoplasm, malnutrition, toxins, things we got to think about. This is Kunasaki's in recess right now. But he's kind of the guy you want on for this because you got to think of some weird stuff. The majority of hypothermias I've seen come in have not been someone laying down in the cold snow, obviously. It's something crazy is going on, and it takes us a few days to figure it out. Also, increased heat loss. This is sepsis. So in our sepsis guidelines, we think of fever and hyperthermia, but also part of the guideline is the patient coming in hypothermic. We had a pediatric come in the other day. We ended up working for sepsis because their temp was 95, and we couldn't explain why, and they're acting weird. So again, you got to think of both spectrums. Burns, obviously burns are a huge deal. This is why people go to a burn center, because they have specialized care. Because you think your body, your skin is a beautiful barrier to keep your thermoregulation. Once you lose that skin, all your heat starts getting lost. And trauma as well. So traditional staging of hypothermia, that's one of those things that you don't really have to memorize, but it's nice to just kind of have in the back of your head. This is the traditional staging, and this is based primarily on temperatures. Again, these are centigrade temperatures. Sorry, that got messed up. But 28, 32, 35, going into a severe, moderate, and mild. Again, just based on temperature. As we all know, temps can be hard to get. They may not be accurate based on your equipment and the patient. It may be hard to get temperature. So this is what they call the Swiss staging, and I actually kind of like this a little better. Because what this does, yes, it incorporates temperatures, but it also gives you kind of typical symptoms and signs that you're going to see for these patients to better delineate what's going on. So in our HT1, which is usually 32 to 35, the patient's conscious and they're shivering. This is kind of your important point right here, the shivering. Once they stop shivering, they're going into these farther realms of hypothermia. And you start getting impaired consciousness as well. So again, if this person comes in and we can't get a temp yet, or they're just too cold, can't really figure it out, we can at least know if they're shivering and conscious, they're on the better end of cold, and we can treat them accordingly. But once we start losing these basic basal maneuvers, the person's obviously sicker and sicker. Any question on that? Again, don't memorize that. It's just to know the spectrum of disease. So physiologic response, like I said, the body is a nice machine that works in a nice little comfortable zone of temperatures. Once we start getting out of those temperatures, things get a little wacky. So first off, neurologically, we've all kind of seen this. People get depressed consciousness, impaired judgment. This is a problem because, again, there's people walking out in the snow. Maybe their car breaks down in the snow. They start walking. They start not acting right. They start not making good decisions. They think it's a good idea to keep walking, keep walking, keep walking. And that's why people are found miles from their car in the snow, because they're not making the best decisions. Slurred speech, shivering as well. Cardiac, initially, obviously, you get tachycardic, hypertensive. You're in a stress situation. You're pissed off that you're cold, so you're going to be acting accordingly. As we move along the spectrum, and I'll show you this in a second, we start getting bradycardia, decreased cardiac output. We've all seen those cold patients come in, their pulse is 30 or 40. So that's going to be your normal cardiac response. EKG changes. There's a couple classic EKG changes. You won't necessarily see them on all your patients, but a couple things we tend to look for. First off, prolonged QRS. So your QRS just widens a little bit. And the second one is the Osborne J-wave, and I'll show you a picture of that right here. This is the second little hump on the back of the QRS. It's a very classic sign of hypothermia. All of us get this on our board exams at some point. There's a really long explanation that I don't understand as to why it happens, but it's not important. But just know that we might be looking for this on EKG. And obviously we're not going to diagnose hypothermia with this. That's what a temperature is for. But we might be able to at least explain these EKG abnormalities and see them go away as we start treating the patient. Respiratory-wise, again, initially you're pissed off, you're cold, you start breathing really fast, you're getting that initial cold shock response. After that, you start getting decreased respiratory drive, decreased lung compliance, the chest wall itself can actually get pretty rigid and hard to breathe, and then eventually respiratory failure. Other systems, renal, you get cold diuresis. This is why patients can come in very hypotensive, especially drowning patients. They get in cold water, all their periphery, their vessels shunt all your blood to the central. Suddenly your kidneys see a big fluid bolus, you start peeing out a lot. These people can be very volume down when they come in. Coagulation, kind of all over the place. You can either decrease your coagulation or increase it. Again, just knowing you're out of that nice thermoregulation zone, so your body's just not acting right. All right, so again, along the spectrum, we can kind of see our different signs and symptoms that we see. As we get into our mild, the patient might be a little ataxic, dysarthric, not making the best judgments in the world, but again, they're shivering. That's important. That's the body's basic response to keep people warm. A person in mild hypothermia can warm themselves back to normal if they're able to shiver. Once they stop shivering, that's the danger zone, because now they can no longer take care of themselves, and they're going to keep going down the spectrum. Obviously, as we get into severe, we start getting loss of reflexes and voluntary motion. We can see our EKG here again. Initially tachycardia, it's eventually going into bradycardia. Once you start getting into the moderate zone, AFib can be fairly common. Arrhythmias, weird blocks and stuff. We start getting our widened QRS, and eventually we start seeing VFib or very significant bradycardia. Any questions so far? Good. All right, so this patient comes in. What are our first steps we need to do to get them going back in the right direction, back to normothermia? Those are three basic things. ABCs, don't make things worse, and start rewarming the patient. We'll go through each of those steps real quick. So ABCs, this is really important. We need to check for signs of life on these people for a full minute. If someone comes in and you know they are cold, stop everything and check for signs of life for an entire minute. Do not let anyone do anything else until you check for a minute. Okay? Signs of life being gasping breaths, very slow pulse, minimal respirations. This is where we want to utilize our ultrasound, our cardiac monitor, and our end-tidal CO2. The reason being, if you start CPR on this person and they actually have a pulse of 20, you're going to kill them. Okay? Their body right now is in a state where they can sustain for a long time. It's super cold. Their heart's pumping really slow, their lungs are going slow, but their entire basal rate has decreased, and they're able to sustain that. So if we come in and start jolting them, start doing CPR and other stuff, we can actually throw them into VFib. Their heart is in a very dangerous zone where any increased stimulation can actually cause a fatal arrhythmia. Just for you guys' information, for RSI, if we say, go ahead and pull us up some sucks, this might be one of the times someone say, hey, hold on, are you worried about hyperkalemia in this person? These people are at very high risk of hyperkalemia from rhabdo and hypoxia. So again, we might just immediately go to sucks, but this is someone we probably want to think of doing a rocuronium in. And resuscitation modifications, the science on this sucks, I'll tell you that right now. But if you wonder why we might be doing some weird things with the hypothermic patients, American Heart and European Resuscitation Council both agree that ACLS should not be done the same in hypothermic patients, but no one knows the right way to do it. The concern is that the very hypothermic heart is not going to be metabolizing the medications as much, and the body won't as well. So because of that, if we keep doing our Q2-3 minute meds, they're going to build up the toxic levels in the blood, and when the person rewarms, it could cause harm to the patient. The other concern is that defibrillation isn't going to work on a cold heart. So what we need to do is rewarm these patients to a certain temperature before we start doing our typical ACLS. But do know that, again, the research and the science on this really sucks, and we don't really know the right way to do it. But just if you have any question why we might be doing some funky algorithm on these people. So this is kind of a combination of the American Heart and the Resuscitation Council guidelines. Again, very poor evidence. But what we're saying is above 35 degrees, that's our normal med intervals, normal defib guidelines. Once you get between 30 and 35, meds are at double intervals. So now we're giving maybe 5 at 8 minutes, we're giving our medications with normal defibrillation guidelines. Once you get below 30, we're withholding all medications. We're not going to be giving these people meds because, again, they're not going to work. We're probably just going to try one big shock. And if that doesn't work, now our goal is just rewarming these people back to above 30 because nothing's really going to work under this. So that might be why we're not giving any meds below 30. CPR is performed at a normothermic rate. Some people teach that you should do it to match the person's rate, 40 to 60 or so. Do it at a normal rate. Again, if we are doing CPR on this person and trying to rewarm them, we need to be doing it at a normal rate. Don't make things worse. Again, avoid CPR in patients with any sign of life, even profound bradycardia. Move and transport the patients gently. This is a very team approach. This isn't grabbing the person off the stretcher and yanking them over. This is a very gentle approach, slide board, whatever we need to do to not jolt this person because, again, their heart can be thrown in to be fed very easily. And also remove cold, wet clothing. We always kind of overlook things like this. We have a cause of the problem and we overlook it. We get tunnel visioned on the resuscitation but forgetting to stop the process. So the person comes in cold and wet, make them dry and warm. So take everything off. So now the rewarming phase. There's a couple different ways to rewarm. There's passive, active external, and active internal. We've all seen these different methods, but we'll go through each one real quick. The passive rewarming, this